Priya, studying BSc RIT third year at Government Kilpak Medical and College and Hospital. I am here to present on the topic Significance of IXOL in Post-Operative Gastrography. Introduction. Early detection of surgical complications after gastrointestinal procedures is essential for optimal patient management. IXOL Enhanced Gastrography is a water-soluble contrast imaging technique that provides clear visualization of post-operative gastrointestinal anatomy and facilitates early identifications of complications. This imaging approach supports timely clinical intervention and contributes to improved patient outcomes. Aim to evaluate the diagnostic performance of IXOL enhanced imaging in post-operative gastrography for early detection of surgical complications and to assess its impact on timely clinical intervention and improved patient outcomes. What is post-operative gastrography? It is a diagnostic imaging procedure that is used to evaluate the condition of the GI tract after surgery. The procedure involves administration of the contrast agent, typically via oral or rectal routes, followed by imaging techniques like computer tomography or fluoroscopy to visualize the anatomy and detect the post-operative complications. Indications of the procedure include anastomotic leaks, detects any leaks from surgical connections, bowel obstruction, identify blockages. Stitches help diagnose the areas of narrowing in the GI tract. Infections of abscess helps in identifying localized infections. The contraindications of the procedure include allergy to iodinated contrast media, severe renal impairment, dehydration, hyperthyroidism, pregnancy, severe heart failure, multiple myeloma, active GI tract bleeding, severe liver diseases. Why the procedure is so important? Evaluation of surgical outcome determines the success of the surgery. Detection of anomalies identifies unexpected complications. Assessment of GI tract function. It demonstrates how well the GI tract is performing. Minimizing long-term complications by early detection. Guiding further treatment for planning additional interventions. Visualizing stomach emptying and acid reflux. Diagnosing motility issues. Guiding nutritional management to plan a safer diet for the post-operative patient. Objective documentation act as a clinical record of GI status. Materials required: IXOL, radiographic equipment, fluoroscopic machine, crash cart, gloves in hospital attire, towels and absorbent pads, pillows and cushions for patient comfort. Patient preparation includes pre-procedure assessment, evaluate for contraindications and other blood reports. Number 2 is fasting, usually required for optimal imaging. Number 3 is an informed consent, ensure the patients understand the risk and the benefits of the procedure. Number 4 is laxatives or enemas that can be given for rectal administration. Number 5 is vital monitoring. Patient stability pre and post procedure has to be monitored. Number 6 is instructions to the patient. The procedure steps you want the patient to do and expectation you want the patient. Workflow of gastrography involves taking a plain scout film which acts as a baseline radiographer prior to the contrast agent. The second one is the administration of the contrast agent via oral or rectal routes. Third one is real-time fluoroscopic imaging that captures the dynamic movement of the contrast of the esophageal transit. Fourth one is the positional adjustment that can be made for the better visualization of the anatomy. The last one is the radiological interpretation. Selection of the contrast agent. If a patient needs gastrography, he has to be evaluated about his previous history, whether he is having a perforation or not. If perforation is not suspected, we can go with the routine barium sulfate, which gives better mucosal coating. If it is suspected, we can go with the water-soluble contrast agents such as IXOL or gastrographin. If a patient is a post-operative adult or a deliberated adult, we has an increased risk of aspiration, mainly in pediatric cases, we can go with the IXOL contrast agent. If not, we can go with the gastrographin. Why gastrographin cannot be used in cases of aspiration? Gastrographin being a hyperosmolar contrast agent, it draws more amount of fluid into the alveoli, thus it causes pulmonary edema and then it finally leads to pulmonary distress to the patient. IXOL, a safer contrast agent due to the following properties: non-ionic and lower osmolality, neutral pH, lower nephrosity risks, minimal allergic reaction, better patient tolerance, versatile use. Why not gastrographin? Aspiration risk, fluid shift and dehydration, blood hyperosmolality, hyperperistalsis and diarrhea, solidification and precipitation, toxic bowel effects. Here is a table that demonstrated the type of contrast which can be used in particular situations. For example, barium sulfate is an insoluble contrast media, can be used in routine GI tract imaging but due to its high mucosal coating and high contrast, but it is contraindicated in cases of perforation. Similarly, gastrographin, an ionic contrast media, can be used in cases of perforation, bowel obstruction. It will permit rapid intestinal transmit, but it causes severe pneumonitis when it is aspirated. Ioxol, a low osmolar contrast agent. Due to the lower osmolarity, it can be used in cases of postoperative and high risk cases, but the only limitation is its higher cost and limited availability. Here is a table that demonstrates the property differences between Ioxol and gastrographin. This is another table that demonstrates the property differences between Ioxol and barium sulfate. Case presentation 1, a 65-year-old male with a history of CA stomach. The surgical procedure underwent is gastrectomy and esophagojejunostomy. The impression suggests that it's a normal study and no evidence of contrast leak is seen. Case presentation 2, a patient with a history of squamous cell carcinoma esophagus. The surgical procedure underwent is esophagectomy, gastric pull-up, stomach replacing the esophagus. This impression suggests that it's a normal flow of study and no evidence of contrast leak is seen. Case presentation 3, a 27-year-old male with a history of gastric perforation, suspected Graham's patch, surgical procedure Graham's patch, suspected recurrent perforation after the Graham's patch. You could see the contrast leak into the pelvic cavity, which may be from the post-operative site. Case presentation 4, a 47-year-old male with a history of CME stomach. The surgical procedure underwent is subtotal gastrectomy and esophagojejunostomy. This impression suggests that it's a normal study. Case presentation 5, a patient with a history of positive corrosive poisoning. The gastric antral suture was noted and surgical procedure underwent is antrectomy and the impression suggests that it's a normal study. Case presentation 6, it is a pre-operative study. It was done on a 35-year-old male with a history of necrotizing pancreatitis. The imaging features that a presence of a duodenocolonic fistula with an associated collection which shows communication with the bowel and with the drainage tube in situ. Case presentation 7, a 57-year-old male with a history of corrosive acid poisoning. It is a pre-operative case. The impression suggests that diffuse esophageal stricture is noted involving the mid-esophagus with the proximal esophageal dilatation. Discussion. For postoperative gastrography, barium sulfate is contraindicated due to its severe inflammatory and fibrotic complication when leaked into the peritoneal cavity, lungs or the mediastinum. Similarly, gastrographin possesses a significant risk of aspiration due to its hyperosmolality, but the lower smaller contrast agent like Ioxol have significantly demonstrated with milder tissue reaction, making them the ideal safer alternative. Conclusion, Ioxol is a safe and effective contrast agent for post-operative gastrography, enabling early detection of complications, and its rapid absorption and minimal peritoneal irritation makes it ideal for routine use in post-operative gap. The dynamic imaging enhances the diagnostic accuracy and provide timely intervention. These are my references. I would like to thank the HOD of our department, Dr. Gopinath sir and Mr. Marimuthu sir, for their invaluable support and guidance throughout my work. Thank you.